Good evening, viewers. My name is Rahul Desai, and I hereby welcome you all to today's module on special occasion of World Diabetes Day. Dear viewers, the theme for World Diabetes Day 2021 is to provide access to diabetes care. And this session is brought to you by under the educational initiative by India's first and only brand, Enerzal Zero, which offers zero calorie, zero sugar. Dear doctors, undoubtedly, this is India's longest weekly CME module where Dr. Sanjay Kalra every week on Sunday at 9 p.m. takes the journey, which was started from 26 January 2021 under the vision of Dr. K.K. Garwal sir. And after his timely death, his able disciple Dr. Sanjay Kalra took over. Dear viewers, today we want to bring in the global perspective by an Indian for thousands of Indian doctors practicing diabetes from the World Nucleus Center of Diabetes, that is Jocelyn Diabetes Center. Doctor, I hereby take pride in welcoming Dr. Om Ganda, who is the clinical investigator and senior staff physician, director of lipid clinic at Jocelyn Diabetes Center, and associate professor of medicine at Harvard Medical School, Boston, USA. This session will be moderated by our very own Dr. Sanjay Kalra sir, who is president-elect of South Asian Federation of Endocrine Societies, consultant at Bharti Hospital Karnal, visiting professor at AIIMS Rishikesh, and section editor of endocrinology of APA textbook of medicine. So dear viewers, like me, you too are very eager to listen to our speaker, Dr. Om sir. And with this, I hand over the platform to our speaker and moderator. Over to you, sir.
Thank you, Rahul, and warm greetings to everybody who's logged in with us today. Also, warm greetings to Dr. Om Ganda. Sir, welcome back home. Welcome home.
Thank you.
Today is World Diabetes Day, and this day reminds us that we have to keep on working for better and better diabetes care across the world. Our theme is about access. It's not only about access to diabetes care, in the sense about access to medicines or insulins or diagnostics. It is also about access to diabetes care expertise, which means that all of us, physicians living in India, working in India, living and working for India, need to equip ourselves with the expertise required to manage diabetes. To get expertise, we need expertise, isn't it? So today is also about access to the best expertise that the world has to offer. And that is what we bring to the table today, to Diabetes Essentials today. We bring you access to the expert of the world. Dr. Om sir, warm welcome to India. You have nearly 20,000 people logged in today to listen to you. We have lots of challenges when it comes to managing diabetes. We need to talk about diagnostics. We need to talk about monitoring, screening. Also, we need to talk about therapy, which can be non-pharmacological, pharmacological, which can be surgical also now these days. But would you like to speak to us about a rational approach to diabetes care? And you already have tens of questions even before you've begun your talk, waiting for you. But we are looking forward to listening to you, sir. A rational approach to diabetes care, evidence, along with your experience, along with the eminence that you bring to us.
Thank you very much, Dr. Kalra, for that very kind introduction. It's really wonderful to be joining with all of you today on this World Diabetes Day. I hope everyone had a great Diwali season. And now in this session, today I'm going to try to really summarize a lot of information, but I look forward to the interactive discussion that will follow and the questions from the audience. So let me just share my screen and see if you can see my slides. Let me just cut to that. Can you see my slides? Okay.
It started. Yep.
Okay, wonderful. Today's topic that was assigned to me has to do with diabetes management, a pragmatic approach. All of you are very familiar with a lot of information that is occurring in the literature and we hear a lot about some of the recent advances. But I'm going to try to give you an overall approach, which I think might be useful. So let me just get to the slideshow here. And today is, of course, World Diabetes Day once again. To start with, I want to mention my disclosures here that are shown in this slide. Let me just see if I can get rid of this bottom strip that is hiding. One second here. Yeah, okay. So on this World Diabetes Day, I don't think I need to inform anyone that it was 100 years ago that insulin was discovered. And shortly thereafter, it became available all over the world. So we celebrate this day by painting some of the buildings and lighting them in blue. Here is the Joslin Diabetes Center, where I work in Boston. And here is a depiction of one of the tall buildings, the Prudential building. You can see the blue lighting all around. So that just to commemorate this very, very important day. So these are the 4 different players that led to the discovery of insulin. You all know that the Banting Award was, the Nobel Prize was awarded to Fred Banting and his medical student associate, Charlie Best. But honestly speaking, and we have heard a lot about the controversy about the Nobel Prizes, 2 other people who were very instrumental in making the insulin molecule available to the rest of the world were John McLeod, who was actually the chief of the department, but even more importantly, James Collip, without whose help insulin probably could not have been purified to the extent that it could be used in human beings. Anyway, so this is a long story, but because today is the World Diabetes Day, I just wanted to mention, I know we've had a lot of presentations this year on the centennial of the discovery of insulin. Okay, so these are the objectives of my talk today. I will highlight diabetes as a global pandemic with dire consequences, as Dr. Kalra just alluded to. I will summarize the evidence-based cardiovascular and renal outcomes with the newer anti-hyperglycemic agents. I'll then go on to describe the justification and circumstantial benefits of some of the older agents, if not all. And finally, we'll develop a practical approach to overcoming treatment inertia. This is a huge problem all over the world, with emphasis on the relevance of shared decision-making and promoting patient empowerment to mitigate complications. We all have wonderful ideas about it, but unfortunately, we need a lot more inway into this very important problem of therapeutic inertia. I also want to dedicate today's talk to the memory of Dr. K.K. Agarwal, who I know that as a famous cardiologist was well known to most of you, and he was putting together a number of talks like this for general public as well as physicians involved in the human health. It is actually ironic and unfortunate that a few months ago, I was actually invited by him to make one of the presentations, but soon thereafter he passed away. So that's one more reason I wanted to dedicate today's talk to Dr. K.K. Agarwal. Okay, so speaking of the IDF projections and population statistics, just one slide to summarize this. You know from the most recent diabetes atlas that was published in 2019, there were 463 million people living with diabetes around the world. And unfortunately, India has almost 25% of that number. And now, actually, you will see it published in a couple of weeks, early part of December, but they just announced the 10th edition of the Diabetes Atlas just this week, talking about the pandemic of diabetes that we face long before the COVID pandemic came along. So you can see that, unfortunately, in spite of all the headways and progress in research that has been made, number of people with diabetes continues to rise. So as of 2021, there are actually not 463, but 537 million adults 20 to 79 years of age who are living with diabetes in the world. Let me just minimize this here so you can see it. And this number is predicted to rise to 643 million within this decade, by the end of this decade, which is really a very, very humbling statistic. Not only that, but over 4 in 5, that is 81% of the adults with diabetes are living in low and middle income countries, including India, rest of the Asia, and many other countries in the world. Diabetes is responsible for 6.7 million deaths in 2021. Huge number. I won't even get into the cost. These are the costs for United States, but you can see on the bottom that in addition to this number, there are many, many more people with impaired glucose tolerance. Let me see if I can get rid of this bottom line here. Okay, in any way, I think you can see the bottom line with impaired glucose tolerance. So the scope of diabetes is really, really humongous and very, very humbling. Now, we also know, based on many statistics that have been published, about the fact that cardiovascular complications account for most of the deaths in the patients with diabetes. This is a very, very large data collection from 102 prospective studies, more than 600,000 people, 8.5 million person year. You can see that compared to people without diabetes, all cardiovascular outcomes occur about 2 or more fold higher in their rate compared to people without diabetes. This is a multivariate adjusted comparison. And this includes strokes, most of the strokes being ischemic strokes. It has also been calculated, this is actually relatively older data now from about 10 years ago, that diabetes causes a major loss of life years, not even including the loss of productive life years. So if you develop diabetes at the age of 50 and you have no history of vascular disease in the past, you lose about 8 to 10 years of your lifespan over the course of people with diabetes. So this is again very humbling statistic. We know that controlling glycemia, no matter how you do it, it reduces microvascular complications in both type and type 2 diabetes. Now, this is going back to fairly large data in the old literature now, DCCT study in type 1 patients and Kumamoto and UKPDS in type 2 patients. And you can see, while we're still following these people in the DCCT, in the EDIC trial, but in the first 5 years, if you bring down the hemoglobin A1C from 9 to 7%, you reduce retinopathy, nephropathy, and neuropathy incidence by more than 50 to 60%. And this is the first time we showed that Dr. Jocelyn, who was one of the most vocal believers in glycemic control, he was right all along, except he did not have any clinical trial data to prove it. And of course, in UKPDS, a fairly large study like the DCCT, they were able to lower the A1C from 8% to 7% and saw about half as much benefit as you see from 2% reduction in the DCCT. So it doesn't matter whether you have type 1 diabetes or type 2 diabetes. Kumamoto also studied type 2 diabetes with 2% reduction. You have very, very significant and impressive reductions in microvascular complications. But what about macrovascular or cardiovascular complications? This has been very controversial in the past because we were not sure if we could lower the A1C to 7% or even lower, will it lower the cardiovascular outcomes to the same extent? The first study to show that after UKPDS was actually the study called ACCORD, along with 2 other studies, the ADVANCE study and the VA study. All 3 studies showed that in spite of lowering the hemoglobin A1C by intensive control, with hemoglobin A1C goal of about 6%, but they were able to lower it to about 7%, you can see that there was a modest and not really significant difference, except in the Accord, where there was a just about significant difference. So overall, if you add all of these studies, you can see only about 15% reduction in cardiovascular outcome with a fairly good hemoglobin A1C management. Not only that, but what was really disturbing is that when you control the glucose very tightly, especially in older people, many of the patients in these trials, in fact, most of the patients had about 30 to 40% prevalence of cardiovascular disease, and the mean age was about 55 to 60. So you can see in such a population, even tight control not only made not much of an impact on cardiovascular outcomes, but actually in the Accord study, there was a 22% increased mortality, in spite of the fact that the cardiovascular outcomes were reduced. So this was very disturbing. And up to this day, we don't know the exact cause, but we think that it could have been due to recurrent severe hypoglycemia, because in order to get to very tight hemoglobin A1C, most of these patients eventually ended up using insulin in combination with several other oral agents. So with that background, I don't have to spend any time of this. You know that we have about 15 classes of drugs these days that can help lower glycemic control. And I won't go into any of this except to mention them as we talk about the trials, but the age-old drugs like metformin and sulfonylureas, we have been aware of them for many, many years. 1997, we had TZDs become available, then glucosidase inhibitors, then incretin agents and Sglt2 inhibitors, and so on and so forth. So in the past only 6 years, there have been many trials with some of the newer agents, including incretin agents, DPP4 and GLP-1 receptor agonists, and Sglt2 inhibitors, that have shown a dramatic advance in the management of type 2 diabetes, because not only these drugs improve glycemic control, but they have specific effects on cardiovascular and even renal outcomes. This is at least partly facilitated by their pluripotential effects on cardiovascular and renal system that I'll summarize briefly as we go along. So in spite of all this happening, what is the uptake of these drugs in general population, and how much benefit are we receiving in the population as a whole? That's part of my presentation today. So the first set of drugs that went through the cardiovascular outcome trials, because this was mandated by the FDA in 2008, they said that all drugs, all new drugs must go through cardiovascular safety trial, because it wasn't clear whether some of the newer drugs will actually be beneficial to the heart or at least neutral for the heart safety. So to make long story short, these are 3 DPP trials using saxagliptin, alogliptin, and sitagliptin. And you can see in all of these fairly large trials, going from about 2 to 5 years, there was actually good documentation of cardiovascular safety. They did not provide any additional benefit to the standard of treatment, except for the fact that they're easy to use, once-a-day medications, but they also showed no particular disadvantage from the cardiovascular point of view or renal point of view. So that was very reassuring, the first set of trials that were carried out after the FDA mandate. So what about GLP-1, and why is it receiving so much attention? GLP-1, as you know, is one of the 2 major incretin hormones that we produce in our gut every time we eat. So postprandially, the GLP-1 and GIP levels go up. But what was not appreciated until more recently is they have numerous potential effects on cardiovascular system. There are GLP-1 receptors, many parts of the body, and for example, the myocardial GLP-1 receptors are involved in cardioprotection. In the kidney, they cause natriuresis and diuresis. They also reduce blood pressure. Very importantly, they act on the brain to improve satiety. So part of the reason people lose weight on these agents is not because of the GI effects only, but because the central mechanism of effect on the satiety. Therefore, people tend to lose weight. They also are anti-inflammatory. They reduce postprandial lipids. they reduce coagulation, and we have known for a long time that they are potentially useful in beta cell regeneration. Although this has never been proven in human beings, but we know that they do improve beta cell function, as well as they suppress glucagon by inhibitory effect on the alpha cells. So thereby, they are free of hypoglycemia if used by themselves or with agents that don't cause hypoglycemia, because the effects are only glucose dependent, and they only work when the glucose levels are high, and the effect dissipates when the glucose levels come down towards normal. Now, I can spend a lot of time talking about these cardiovascular trials, but the best thing is to really summarize this. And you can see in the 7 different GLP-1 trials carried out and published since 2015, you can see the 3-point MACE, the major outcome of cardiovascular events, was reduced by a significant 12%, highly significant, not very large, but again, this is on top of statins, for example. Everybody or most people in these trials who had high cardiovascular risk were on statins and other standard drugs for cardiovascular protection. So on top of the state-of-the-art cardiovascular treatment, beta blockers, ACE inhibitors, statins, aspirin when needed, they still were able to reduce the cardiovascular event by 12%, very highly significant. In addition, putting them all together, 12% reduction in the cardiovascular death and 12% reduction also in the cardiovascular mortality. So this was totally unexpected. And in fact, it was very widely received as a good news. You can see individual trials, there's a little bit of difference. For example, this was not shown significantly with some of these agents, such as the Elixir trial with exenatide, but was most importantly first shown with liraglutide and then semaglutide, shown here in SUSTAIN 6. And again, Rewind, which is a study with dulaglutide, there was a significant difference as well. So putting it all together, they seem to have major benefits. Now, what about the adverse effects and caveats to keep in mind? We all know that they cause GI side effects, particularly nausea, in some cases vomiting, and patients have to be started on a lower dose. The advantage is now that we can use these drugs once a week, and several of these drugs are available once a week, and the effect seems to be less severe in patients who start once a week therapy, and the effects generally dissipates within the first few weeks. So very few people actually discontinue these drugs, but it does become a problem for some people to the point that they may have to discontinue it. There is a mild to moderate increase in the incidence of biliary disease or worsening of the biliary disease that has been talked about, and a very rare situation where somebody has history of medullary carcinoma of the thyroid, either personal history or family history. These drugs are not yet indicated, even though this effect has not been shown in clinical trials. It comes from the animal data. Okay, what about Sglt2 inhibitors? Well, this is another very important class of drugs that has kind of produced a paradigm shift, so to speak, in our management. They're easy to take, they're once-a-day pill, and they also have numerous effects on both cardiovascular and renal systems. So speaking of the mode of action, of course, they call glycosuria by blocking the Sglt2. So glycosuria leading to loss of calories is partly responsible for some modest weight loss, 2 to 3 kilograms. They reduce hyperglycemia by overcoming this glucose toxicity, so to speak. And finally, they also have other effects like natriuresis, diuresis, and uricosuriya. And some people would say that a reduction in the uric acid is also a protective factor for cardiovascular disease. In addition, by hemodynamic effects and other effects not fully displayed here, perhaps slight increase in ketogenesis, they have very salubrious effects on the heart, and they are responsible for cardiovascular outcome, in particular heart failure. Heart failure is one of the most common complications with type 2 diabetes, as you know, more so in obese people and more so in people of long duration, even in the absence of coronary artery disease. So again, to summarize all the trials, In fact, the very first trial that was ever presented among all the newer drugs, GLP-1s included, was the EMPA-REG outcome trial in 2015. And how much has happened in 6 years? We have about 10 GLP-1 trials and 11 different SGLT2 trials. The first 4 are shown here. Vertis was the last one, but the first 3 shown on top. You can see they reduced the 3-point MACE modestly by about 14%, at least in these 2 trials, which was very similar to the liraglutide trial and later semaglutide trial, but a little bit more modest than semaglutide. They reduce cardiovascular death depending upon which trial you look at. It was particularly shown with empagliflozin. Others were not significant. But most importantly, and this is the take-home point, that the major effect happens to be on reducing the incidence and progression of heart failure. You can see here remarkable benefits leading to cardiovascular mortality reduction, 35% reduction in heart failure, EMPA-REG, 33% in CANVAS, 27% in DECLARE, and even Vertis, which was not overall positive for MACE, showed 30% reduction in heart failure. So this is truly remarkable. And in selectively following those people who have high risk of heart failure, these have become the drug of choice. But I'll come back to later why they are not being used still, partly because of the cost considerations. But I want you all to know that scientifically, there's no doubt that they have very prominent benefits, although we still need long-term actually follow-up of some of these patients, because the first trial just came out in 2015. So it's only been a 6-year story, as opposed to many of the other diabetes drugs like insulin, which we've had for more than 100 years. Okay, one of the other points I want to make with the SGLT2 and heart failure story is that we have known for a long time now, well, relatively long time, that people with reduced ejection fraction not only get benefit from this kind of treatment modality, but even people without diabetes now, in these 2 trials that are shown here, EMPEROR reduced and DAPA heart failure, dapagliflozin and empagliflozin. Imagine that, totally unexpected, that people without diabetes with heart failure also benefit to the same extent as people with diabetes. You can see fairly large number of people compared to placebo here. We're talking about fairly large numbers. Okay, now moving on further, one last point about the SGLT2 is this trial called the EMPEROR Preserve, which is the first cardiovascular trial that was published just several months ago now in people with preserved ejection fraction, because everybody was thinking that maybe they're only good for people with reduced ejection fraction. So here's the latest trial, about 6,000 people, baseline heart failure, class 2 to 4, ejection fraction above 40%. Okay. Now, some would argue that it should be cut off at 50%, and I think that's kind of a point we can discuss later. But people with ejection fraction over 40% now currently defined as a preserved ejection fraction. Over the course of 2 years, you can see a 21% reduction with empagliflozin compared to placebo, and the same data was shown is actually likely to be shown with other studies, like sotagliflozin already has shown in a sub-analysis. Sotagliflozin, as you know, is SGLT1 and SGLT2 inhibitor, but that one also showed a similar effect on people with ejection fraction over 40%. So this is quite remarkable also. Okay, what about their adverse effects? Because I think we always have to balance when we talk to the patient what kind of adverse effects they can expect and how to really mitigate those adverse effects. Well, the most common effects, first of all, they're tolerated very well. Okay, as an oral pill, no GI side effects, but they do have an increased incidence of genital mycotic infections, about 3 times more commonly in women than in men. So if somebody has occasional Morellia infection, that can be treated, but women with recurrent Morellia infection may have to stop these drugs because it becomes kind of difficult on top of their recurrent Morellia infection history. Okay, another very important point, not very common, but they can cause ketoacidosis in anyone who has poor beta cell reserve. So this is not only people with type 1 diabetes, where of course they're not even indicated. One should not be using them in type 1 diabetes. But if you do use them, then in type 1 diabetes, the incidence of DKA is much more common than in people with type 2 diabetes. And the strange thing about this is that because the way they work, they cause ketogenesis, and you can have DKA in the absence of moderate to severe hypoglycemia. It can be like blood sugar of 150 to 250, which may not be considered very high postprandially, but it can occur even in that setting. So patients need to be educated. The incidence in type 2 diabetes is very small. I would say no more than 1 to 2%. But again, if somebody's coming to the hospital, I would stop the Sglt2 inhibitor 1 week before they come to the hospital if it's a planned surgery or planned intervention that requires hospitalization. Because any level of stress, dehydration, hypovolemia will make the possibility worse. Their indication is by eGFR. It varies by agent. This is actually getting better now, and because of the renal trials, it seems like you can judiciously use these drugs even in people who have GFR as low as 45 and continue these drugs as long as GFR is above 30. So this is all new within the past year because of the new trials that have looked at people with kidney disease. There was an initial concern that they may increase the risk of distal amputations, mostly toes or in the foot area. Fractures were not confirmed, and even distal amputations now have not been confirmed in much larger number of people. So I would really strike this out. In fact, this black box warning by the FDA in the label has now been removed. Very rare, a recent report of retinal vein occlusion, mostly seen in people with older age and CKD, but again, very, very small, just one report. So I wouldn't really put too much stock on that, but keep that in mind. And finally, extremely rare condition, less than 1 in a million has been reported where somebody may develop Fournier's gangrene or necrotizing fasciitis in the pelvic area. And again, extremely, extremely rare. So just wanted to bring you up to date on the current status. And finally, of course, cost, which is true of all new drugs, even more so with Sglt2 inhibitors, at least in our country, in the US, where I practice. Okay, now I won't have time to go into all of the other trials, particularly focused on CKD, but I already alluded to the fact that now there are 3 trials. Credence was the first one, and these are unique, not only because the cardiovascular trials with Sglt2 inhibitors showed effects on proteinuria and reduction in renal disease advancement, but these 3 drugs have been planned with people with CKD at baseline. Okay, in order to get into these trials, you had to have a proteinuria of 300 to 500 milligram up to 2000 milligram, or you had to have GFR below 60. So first such trials was Credence, just beginning of last year, which showed major benefits in the kidney disease progression. Then came this year, DAPA-CKD with dapagliflozin, also showed major benefits in the progression of CKD. And knowing how many of our people get CKD with diabetes, I think the idea is first to screen them, not only just with creatinine and BUN, but with proteinuria. Even in countries like United States, it's not being done routinely. So the early stages, early CKD can often be missed if somebody does not check for microalbumin and later on the quantitation of total albumin level. One more trial yet to come, hopefully next year, will be EMPA-Kidney. So we'll finally have 3 trials, but the first 2 have shown major benefits, and I'll be very surprised if EMPA-Kidney does not show the same thing, because the effect seems to be class-specific rather than individual drug-specific. Okay, now let's move on to diabetes management and what are the guidelines and how do we use those guidelines in global territories, including countries like India. Well, there are lots of guidelines, okay? We all know that. ADA, ESD, the most commonly used guideline, ACE, Canadian, NICE in UK, American College of Physicians, Cleveland Clinic guidelines, our own guidelines, somewhat different because we try to be a little bit more proactive, Mayo Clinic, VA and Department of Defense, and many, many more. So at times people get confused as to which guideline to follow, but I think if you simply follow the most well-known ADA, ESD, you get the picture because most of them are very similar in their scope and in their suggestions. So I just want to mention the latest guideline. Now, of course, the ADA guidelines along with ESD are revised 2 or 3 times a year as needed. So that has helped keeping the latest guidelines in perspective. So most important thing is that the goal of care should be to prevent complication and optimize the quality of life. The other goal is to agree on the management plan in a given patient, given a number of issues, so-called the SMART goals. And finally, we need to talk about patient preferences. We need to talk empowerment of the patient. We talk about the individual choices, caregivers in some cases who are heavily involved because of the patient's clinical condition. So I think much of this is really common sense. And I always make the point that guidelines are never meant for individual patient. Guidelines are meant for groups of people, but not for individual patient. So when I see a patient who's sitting in front of me, I have to really use the guidelines, but also use personal judgment. Now, most important point from these new guidelines is, based on what we just talked about, is that first thing you want to ask a patient, is there, or look into a record and see, is there a patient who has established cardiovascular disease, atherosclerotic cardiovascular disease, or CKD, or history of heart failure, or if this patient has very high risk for these events, although most of the studies looked at people with established cardiovascular and kidney disease. So independently of the baseline A1C, this is something new because we know that these drugs work regardless of A1C, independent of the A1C target that you might have, and independent of the metformin use. Most people, of course, do start with metformin first, but even if the control is achieved, you still want to consider these agents. Sglt2 inhibitors, if you have a history of heart failure or high risk for heart failure, this is likely to be changed again now because of the EMPA preserved. So far, it was only recommended for people with reduced ejection fraction, or if they have progressive CKD, not just early stage CKD, GFR 60 to 90, or say albuminuria in the 30 to 100 range. That's not where you want to use these drugs. But if you have an established CKD, then again, SGLT2 inhibitors are preferable. People with atherosclerotic cardiovascular disease, the first line of drug on top of these caveats that I mentioned is a GLP-1 inhibitor, okay, because they seem to have more of an effect on atherosclerotic process than the SGLT2 inhibitors, which have more hemodynamic effects. But SGLT2 inhibitors can be used, given that they do have modest benefits, if GLP-1 receptor agonists cannot be used. And some people would even ask, well, why not use them together? Those trials, I can tell you, are not yet done, but we'll someday be actually looking at that new evidence. Okay. Now, what about the rest of the people who don't have either atherosclerotic cardiovascular disease or kidney disease? Say about 60 to 70% of people that we see every day in our practice. They don't necessarily have an indication for these drugs. The goal is to still achieve targeted glucose control, and one can use any of the drugs after metformin, DPP-4, GLP-1, SGLT2, or even TZDs. But the major issue comes up in countries like India and many other countries, the cost. Can't we use the older drugs still? And that's one of the points I want to make here. I'll come back to that in a minute. Now, in spite of all that progress, I still have to go back and talk about where we are today. This is the NHANES data just published in New England Journal this year with 6,600 people over the course of the last, say, about 20 years that have been followed. You can see that in spite of all the availability and all the great drugs and all the great education we think we provide, people with hemoglobin A1C of less than 8%, 8% is only about 70% people, but ideally, the goal, if you have a less than 7% goal, the actual number of people achieving that is about 50 to 55%. If anything, you can see the number has gone down in the last 3 years that this trial looked at. And that's very disturbing. We think part of this reason could be that Accord study came out around this time, 2010, and then people thought, well, glycemic control doesn't do very much. It's killing more people to be very intensive. So let's just pay attention to blood pressure and LDL controls. And that's not necessarily true, depends upon the patient. Blood pressure control, we're doing better, but still, if you look at 130/80 goal, still not where it should be. Half the people are not in good control. Lipid management, non-HDL, or even if you look at LDL, only about 55% of the people getting to that goal. And if you combine all of these three together, paltry 23%, 22% of the people are getting all three goals together. So in spite of all the progress, we already talked about the increasing number of people with diabetes all over the world, partly because we're living longer and partly because we think that obesity is a major factor all over the world that's not helping us with glycemic goals and the glycemic targets. But still, it is very disturbing that in spite of all the knowledge and all the trials and drugs that we talk about, only 22%, 23% are getting these three major goals, which are highly required for both cardiovascular disease and renal disease and overall mortality reduction. And here is the data on the new drugs as of now. You can see, just focus on the left side. If you look at DPP-4 inhibitors, yes, we're doing better now, but still only about 10 to 15%, depending upon which study you look at. But if you combine Sglt2 inhibitors and GLP-1, the overall use is about 5% as of 2018. It's getting better, but still way below what it should be. So there have been a lot of obstacles and stumbling blocks in the adoption of these drugs, and we need to work on that better. You can see that use of lipid-lowering medications also not where it should be. Okay, what about global picture? Well, this is a very nice study that was published a couple of years ago. This looks at the achievement of guideline targets in A1C, blood pressure, and lipid control in type 2 diabetes globally. So this is 20 different countries. I'm not sure if India was included in this analysis. More than 370,000 people here you can see. And once again, A1C target reduction to less than 7% was only 43%. Blood pressure reduction even to 140 over 90 versus 130 over 80 in people with cardiovascular disease was about 30%. LDL goal being achieved in only about 50% or less than that. So I think we have a lot of work to do as physicians and as caregivers. We need to somehow come back to the basics of what the patient will accept, what the patient can afford. So the root of the problem, I believe, is really the treatment inertia as well. It's not only just the patients, but ourselves. We sometimes, don't have the time because we see so many patients a day that it's not possible to really get to all the details in one sitting with a given patient. Let me just go back here to this slideshow. So what are the reasons for that and how can we change it? Well, American Diabetes Association recently has come up with a 3-year plan to improve therapeutic inertia and to talk about one of the most important things, one of my favorite topics when I talk to the patient, and we learned that from DCCT and EDIC, that early tide control leads to longer-term maintenance of glycemic control, the so-called legacy effect. We showed that in DCCT and we show that in the UKPDS. So I think, if you start tightening the control, once the patient has not only cardiovascular outcome, but high risk of cardiovascular disease, 15 to 20 years of diabetes, that may be too late. And that's not where we want to intensify control necessarily, because that could lead to more problems. Early diagnosis and early control. I'm not even going to talk about diabetes prevention, But if you ideally want to prevent complications, we have to prevent diabetes. That's another topic that has received a lot of attention. So this is a major problem. Then there are psychosocial issues. Okay, we may not realize it when we first meet with a patient, and patient not be willing to talk about it. But there are a number of reasons why we have to have a collaborative and patient-centered approach, where patients should be quizzed proactively about any psychosocial issues that might have, their family life, their personal life, their job situation, and underlying history of diabetes, distress, and depression, and so forth. So assessment for symptoms of diabetes, distress, depression, anxiety, disordered eating, and cognitive capacities, all of this are very important to keep in mind. And of course, as people get older, they get more cognitive issues to deal with, and this is a huge problem all over the world. So let me just say a couple of words about problems unique to India and other regions like India. And this is important to keep in mind about our approaches as we are trying to do our best to improve the healthcare outcomes. Well, we all know that we don't have adequate resources. Physicians are very busy, and they see many, many patients a day in their busy practice, and there's not that much availability of diabetes educators. Primary care patients are even more busy than the specialists, and they have too little time. A unique problem with the rising population in India, and I know that many new medical schools have been created, and many more physicians are available. But the question is, how many of them are willing to get into practice like diabetes, where a lot more work is needed? You don't have to have an endocrinologist to take care of diabetes. We have to be really training people who are really dedicated to a group of situations like diabetes with high risk for cardiovascular outcomes. So I mentioned already, with very limited diabetes educator availability. I would like to hear from you how much effort you are making and how much of this is available now. I know there have been efforts made in some parts of India. There are lifestyle concerns. We know that in India, high carb intake has been a factor. Many people are pure vegetarian, and they don't get enough other food constituents, and less protein intake and high carb intake are not conducive to very good glycemic control. Although the type of carb makes a difference, and we can still make a difference by avoiding certain carbs that have higher glycemic index. Physical inactivity, certainly part of that. And this was one thing that happened in the past, many generations ago, where people are much more physically active. I don't need to tell you that. And adherence to treatment regimen. It's not only treatment inertia on the part of the primary care setting, but also adherence to treatment by the patient because of number of reasons. Affordability of medications being one of them. This was a beautiful paper in Lancet 2 years ago. Some of you may have seen. The burden of diabetes and use of diabetes care is a humanitarian crisis in low-income and middle-income countries. And how do we get coverage for these 500 million Indians who may have either diabetes or pre-diabetes? So a lot of this really has been, in our conversations. But I think in this particular article in Lancet, the major question that was asked was, how much is the government likely to get involved? And they have to create a healthcare system where people don't have to pay everything out of pocket, not only just for inpatient, but to keep patients from going to the inpatient setting by treating them as an outpatient. Okay, so I know there are attempts were made and being made by things like Ayushman Bharat, and you can sometimes maybe look at the current status and give me some clues as to what you think is happening at this point. Okay, in the remaining few minutes, I want to talk about something that I alluded to before. What about primary prevention, and what about the older drugs? Are they not effective and safe in reducing glycemic burden as everybody now is talking about, the newer agents, the three classes that I mentioned, two among the GLP-1, DPP-4 and GLP-1 receptor agonists, and the PCSK9 inhibitors. So I just want to mention a few things about this. And I think this is what I call elephant in the room. Okay, we often talk about all these major trials, huge benefit and huge progress that has been made, but sometimes we forget about what is practical, and we ignore the real situation in real life in patients that we see, particularly in primary prevention. So treatment benefit must outweigh the burden of treatment. It's a chronic disease, it's a progressive disease, and there is a lot of things that can be done before you get to the point of requiring some of the newer agents as well. So cost is a major issue. If somebody has established cardiovascular disease, the priorities are different. When people without established cardiovascular disease, even in the ADA guidelines, is clearly stated, you can still use sulfonylurea, you can still use TZDs. And the A1C targets are not met, then you can add the second drug. When the first one was TZD, add SU, and the other way around. And finally, don't forget that I would still use a little bit of insulin in people who cannot get into proper control with these classes of agents, on top of metformin, of course, and think about a very simple program of insulin management. This is some of the data from metformin trials. I know that the data is somewhat limited. The main study that showed the cardiovascular benefits of metformin was UKPDS, as shown here. But there have been some other studies, again, admittedly small numbers, but they have shown cardiovascular benefits. In this one trial with metformin versus placebo, another one metformin versus glipizide, you can see significant benefits in cardiovascular outcome. But these studies were done prior to the FDA mandate, so we did not have very large numbers as we do now. Here is Carolina, the famous study, which was published finally a couple of years ago, which actually for the first time used a DPP-4 inhibitor against a sulfonylurea, glimepiride. And shown here are the hard outcomes of CV death, non-fatal MI, non-fatal stroke. You can see one picture is worth 1,000 words. These two curves were superimposable. No benefit of one over the other if you use them individually. Of course, in real life, we'll often use them in combination. But admittedly, the problem was that, as expected, if you're not careful and if you don't titrate the dose in older people, you will get much more hypoglycemia with sulfonylurea compared to linagliptin in this case. So DPP-4 inhibitors definitely have that advantage, that the effect is glucose dependent and they don't work when somebody is euglycemic to make them hypoglycemic, unlike glimepiride. IRIS. Oftentimes we ignore trials like this. IRIS is a fascinating study that was started many years ago. I must point out that this study was done in people with fatal or non-fatal stroke or MI. That was the primary outcome, okay? And these people had IGT, not diabetes, okay? So they had a high risk of diabetes. They were included in the study because they had insulin resistance, or they had recent stroke or TIA. And the outcome was stroke or MI going forward. You can see here pioglitazone versus placebo, okay? Actually, you can see the cumulative probability of event-free survival. Pioglitazone was better than placebo, keeping the rest of the treatment the same. And you can see that there was a 24% reduction in the risk of stroke or MI. In other words, 24% better survival, 9.3% versus 11.8%. And interestingly, there was no increase in heart failure in this study. So I don't think it's time to throw away the old drugs. And in selected circumstances, in primary prevention, they can be very effective. Acarbose. People tried this. The UK group actually used this drug. They did the study, but most of the people here were Chinese, 6,500. You can see again, the new diabetes development was reduced by acarbose, but otherwise there was no difference in overall outcomes. And finally, the discontinuation rate of acarbose was very high. It's depending on the population that you use it at. And I believe that people with diabetes in India tend to tolerate acarbose somewhat better. Now I cannot advance this slide. There we go. So finally, when 2 or more oral drugs fail, this is my lesson I provide to patients all the time. When we talk about lay people and we tell them that, look, don't keep on adding one drug after the other. If 2 or more oral drugs fail and your A1C is above 8 or 8.5%, it's time to sit down, talk about their diet. Okay, are they having concentrated sweets or sucrose containing drinks? Very common to have regular diet Coke, regular Coke instead of diet Coke, and regular any kind of nutritive substance, and adding to the sweetener overload. Practical physical activity. Okay, avoid using as a threat. Describe it as, and don't think of it as a failure or punishment. My strategy is to give them just a whiff of insulin, so low dose basal insulin, and in some cases GLP-1 receptor agonist as acceptable to the patient, and combine them together if possible to achieve better control. Now, in the last 1 minute, I know we're running out of time, but I just want to mention this one study that is not yet published called the GRADE trial. And this is precisely the question that was asked, that people who have A1C above 7.5%, what is the approach that is the best in achieving better control? Okay, so this was really a primary prevention study, not a secondary prevention study. And it was not an event-driven trial. The goal here was glycemic reduction. The study has gone on for a number of years. It was presented at the ADA this year, likely to be published soon. But here is some of the data. So more than 5,000 people were screened. A1C at screening was high. And then they were given metformin, of course, run in up to 2,000 milligram. And if the A1C remained on the average more than 7.5%, then they were randomized to receive sulfonylurea, DPP-4 inhibitor, sitagliptin in this case, glimepiride, sitagliptin, liraglutide, once a day injection, and then insulin glargine. Okay, so each group was really followed. You might say, well, why not Sglt2 inhibitors? Well, at that time when the study began, Sglt2 inhibitors were not even available. So that's really a limitation of the study. But let's see what happened. These are the main results from the ADA, unpublished, as I mentioned. So this shows you the percent of patients with A1C at 7 and above, and percent who develop cardiovascular outcome in having started with no cardiovascular disease. Only 6% had it at baseline. Follow about 5 years, everybody was on metformin. You can see glargine, people who developed, who were still at A1C above 7, 67%. 68% liraglutide, glimepiride 72, sitagliptin 77. So a lot of people were not in ideal control, but these drugs brought them to the range of being above 7% to about the same extent, maybe a little bit better, actually. And then you can see percent who develop cardiovascular outcomes was not very different. If anything, it was a little bit low in the glargine group, and then liraglutide group, glimepiride group, and sitagliptin group. But look at the cost. Okay, we spent all this money, $5,000 in the US currency, glargine $5,000 a year, total over the trial, $3,700 sitagliptin, glimepiride $200. And you all know this, that we are spending a lot of money on the newer drugs, and many people can't afford it. Okay, and these data are really such that being in primary prevention, there were no differences in mortality, MACE, etc., because this was people with newly diagnosed or relatively short duration of diabetes. So I just wanted to make the point that we do have to consider all of these factors in selecting treatment in improving the glycemic control. So key points to end my discussion and to have some discussion from you. We have come far, but we have to go much farther with a much more thrust needed for diabetes prevention, which of course is #1 priority. The ongoing pandemic of diabetes remains a global challenge despite better management tools and technology. Current clinical guidelines algorithms are more evidence-based than ever before, particularly for secondary prevention. Should pre-diabetes not be part of that? It is actually, because many of the people who were studied without diabetes, some had pre-diabetes, and some of that data has not yet. So when it comes to heart failure, you don't even have to think about somebody who is high risk of heart failure, has had hospitalization for heart failure. These drugs are going to be used more and more in people with or without diabetes, and of course that includes people with pre-diabetes. So that's the one situation. But what I was mentioning before was in primary prevention, if somebody is otherwise getting started now with the first diagnosis of pre-diabetes, who otherwise relatively young and does not have high risk for heart failure, or for that matter, atherosclerotic cardiovascular disease.
At the other end of the spectrum, Dr. Rekha Kadam from Mumbai and Dr. Niaz Ahmed Ansari from Shahada in Maharashtra, they ask about how to control high HbA1c. And I think Dr. Om sir has given you an overview of all the drugs. Certainly no single drug will work. You will need multiple drugs. But then continuing with the questioning, there is a question from Dr. Niaz Ahmed again. Sir, in your practice, what is your favorite drug for obese patients? Your favorite glucose-lowering therapy for a person with obesity and diabetes?
That's a very important question, and I think it's a key question with all the patients that we see. And even in countries like India, obesity is increasing. But we have much bigger burden, actually, countries like United States and in the UK or other European countries and Middle East. So I just feel that overall we have to be very aware that central obesity, even if you're not having high BMI, is a big risk factor compared to people who have otherwise generalized obesity. So I think for that reason, we now have, on top of nutritional counseling, we all know that that's the number one thing, that increasing physical activity, reducing carb intake, and overall caloric reduction to lose weight somehow doesn't always meet the challenge. Okay, we do that, but in addition to that, the most favored drug these days actually has become GLP-1 receptor agonist, and makes a lot of sense to use it because we don't get that kind of weight reduction with any of the other drugs. Either they are weight neutral or they cause weight gain, such as TZDs and sulfonylurea, or insulin even for that matter. And now with the availability of semaglutide in particular, and I thought somebody may ask me about Terzepatite, which is a GLP-1 and GIP-1 combination. Both of these drugs, okay, are really causing major weight reduction, and they become very, very popular in people who are highly motivated. And they may actually be causing some desired reduction in the need for bariatric surgery down the line, okay, if they continue to work. As well as, again, I would make the point that relatively speaking, we don't know how long the effect will last. We think that they will continue to work because we have now about 10 to 15 years of experience with GLP-1 receptor agonists. And now with the once a week availability, most people don't mind taking them because they're easy to use and they have the benefit of weight loss that they're looking for that no other drug does. Now, having said that, let me make one other point. It's a very important point. That is, has there ever been a study with a GLP-1 receptor agonist in cardiovascular outcomes in people who are obese and no diabetes? That's the key question. And I think that kind of study is currently in progress. Okay? There are two studies currently in progress, one with semaglutide and one with Terzepatite. And of course, it'll take some time before those studies are completed. But I think we need that kind of study because worldwide, there's so many people with or without diabetes who are obese, and we don't yet know whether the long-term benefit in cardiovascular outcome will be sustained or not.
Right. So a very clear-cut answer coming from Dr. Om. If you have a person with diabetes and obesity, in India, what you have available is liraglutide, which is once-a-day injection, dulaglutide, which is once-a-week injection. And from January onwards, we will have semaglutide, which is an oral pill. So, of course, they are a bit on the more expensive side, but don't hesitate to speak with your patients about them. And some people may wish to afford or may wish to use it. A question linked to obesity. Dr. Fareed Mohammed from Sirohi in Rajasthan says, is pioglitazone harmful in obese people? I recently read about the TriMaster study where they said that pioglitazone should be used in obese people preferentially.
Well, I think the question is not so much about the obesity. So the question is that of insulin resistance. And so, yes, they can cause some weight gain, but the adipocytes that you produce in response to the PPAR gamma activity of the glitazones is really causing the formation of new adipose cells, which are smaller and more insulin sensitive. So that's the point that really has to be kept in mind, that even if you have modest weight gain, they can still improve, and they do improve, insulin sensitivity. And if you look at the studies like Proactive, which was done many years ago. There were some problems with that study, the way they defined their endpoints. But Proactive was the first study that showed cardiovascular outcomes are reduced with pioglitazone in that case. Then came the controversy with rosiglitazone, and I don't believe that paper, that famous paper, should ever have been published, because it was really based on summation of small number of people in many studies put together. This was really not a kind of study that we would like to see according to the standards in 2021. So I think use it judiciously. I use it in people who continue to be obese, who continue to have insulin resistance. And one example, for example, is like they use more and more insulin, which is not going to be conducive to weight loss. If anything, it'll be worsening the weight gain. So in that situation, you can use it as well. And so even though we have better drugs now, in the sense that they cause weight loss proactively, but in patients with severe insulin resistance, you don't want to end up giving them a high dose insulin, like for example, 50 to 60 units of glargine twice a day, for example. It's a fairly large dose for somebody whose BMI might be only about 27, 28, granted that they have central adiposity. But people with central adiposity actually have more to gain by improving their insulin sensitivity. So it's a very careful decision you have to make, as you do, Dr. Kalra, I'm sure. But it's good to know the cost of some of these newer medications, as you mentioned, is coming down in India. And India is known for coming out with generic drugs before any other country does. So I think that'll be the key as we wait for the generic drugs to become available, because nobody can use these drugs if they don't have good insurance coverage, because they're very expensive otherwise.
From Barmer, Dr. Mehboob Rashid raises the point, how do you link the choice of glucose-lowering therapy with fasting serum insulin? So the question, Dr. Om, to you is, do you do a fasting serum insulin in all your patients? Or do you base it on the phenotype? So can you describe for us the phenotype of insulin resistance? And then let's take another question from Dr. S.H. Zaidi from Dehradun in Uttarakhand. The phenotype of type 2 diabetes due to insulin resistance, the phenotype of insulin deficiency or LADA, and the phenotype of pancreatic diabetes, which remains quite common in many parts of India. Mm-hmm. If we can understand the phenotype, then this is speaking to all of us who are listening to Sir today. We can easily understand in whom to preferentially use insulin sensitizers, whom to counsel about insulin, and in whom to get some imaging done to confirm the diagnosis of pancreatic diabetes.
Right. So these are also important questions. I think, first of all, very, very simple clinical leading to the need for insulin. First of all, I think type 1 diabetes can often be missed by just simply age criteria. And if someone has history of weight loss, in spite of relatively decent control, or even poor control, a recent weight loss is a big kind of a red herring to keep that in mind. I don't know how often GAD antibody is available in India. You can tell me more about that. But I think LADA is it's somewhat controversial now, based on the fact that one should really think about LADA as a late onset, slowly evolving type 1 diabetes. So someone has a history of weight loss or persistent hyperglycemia, ketonuria in the absence of ketoacidosis under stress. Those are all the conditions where insulin therapy must be considered. And glycemic control itself, as I mentioned very briefly, if 2 or more drugs do not bring the A1C down below 8% or so, chances are the addition of the third drug will not lower it by another 1%, if your goal is 7%. So if you're 1% above the whatever goal you have, and you are on 2 drugs, I think it's time to consider low-dose basal insulin, which can be miraculously effective. And we all know that from our experience. When it comes to pancreatic diabetes, yeah, that's still a very important point. A country like India, particularly in some parts of India, where pancreatic diabetes is very common. Again, nutritional approach. They don't need as much insulin as people with, let's say, type 1 diabetes or type 2 diabetes who end up requiring insulin. They lack glucagon. So the risk of decay is actually lower in people with pancreatic diabetes, but glycemic control can be very difficult, and the variability in the glucose levels can be very difficult to manage in the absence of starting insulin as early as possible. So I think that's another condition where insulin would be very welcome news.
There are many other questions. One question relates to SGLT2 inhibitors and the point that you need to hydrate your patients well
Yes.
when you're using SGLT2 inhibitors. In a country like India, however, where there is a lot of heat, where there is a lot of sweating, sometimes one can go into dehydration. And that can be one of the precipitating factors for ketosis. Do remember that there are only three factors which will cause ketonuria or ketosis or ketoacidosis. Number one, deficiency of fluid. Number two, deficiency of carbohydrate. So if your patient suddenly decides to go on a keto diet or go on a fast, then he or she is going to get into trouble if he is on SGLT2 inhibitors. And then number three would be deficiency of insulin. So in such cases, hydration is important. And actually, we have very good medical grade commercial preparations now here, Dr. Om. Enerzal Zero is one example of those, which you can use in your patients. We use it in summer. For me, a preferred indication is heat exhaustion in patients with diabetes. In summer, I think one of the commonest symptoms that I treat in my clinic is heat exhaustion. And you don't need to do any fancy tests. You don't need to do investigations. All you need to do is hydrate your patients. But it is not only just about fluid balance, it's also about electrolyte balance. And actually, that is our quiz question for today. Sir, many people want direct comments from you in yes or no. Dr. Asha Rastogi from Uttar Pradesh says, do you use metformin as a primary drug in newly diagnosed type 2 diabetes still in the USA?
Yes, we do. I think metformin is a drug that has been around for more than 60, 70 years, even longer in countries like India than in US. As you know, with the metformin fiasco, we ended up actually having no DBI type of drug in our country until metformin was reintroduced in 1995. There was a big hiatus. But still, overall, I think metformin is very safe, very cheap, and has some small number of people who cannot tolerate it because of the GI side effects. Or if somebody has advanced kidney disease, you cannot use it. There are new guidelines now. We used to not use metformin based on the creatinine clearance, which was in the label, which was wrong. So now we have a GFR indication, and metformin can use in many more people until the GFR falls below 45, or in older people. We have to be more careful. But overall, metformin is still, in my opinion, in primary prevention, and to start with newly diagnosed people. If the A1C is less than 6.5, you may want to wait. But if the A1C is closer to 7%, then I would definitely start a patient, and that's what all the guidelines say now. So I think that's another important point. And the point you were making earlier about the SGLT2 is very important. I gave the example of requiring inpatient hospitalization, but I think the same logical rationale applies to the fact that countries like India, where the temperatures are high most of the year, avoiding dehydration is extremely important. And that's one situation that causes ketogenesis. So I think it's not only for people who are quite sick, but people who are otherwise in regular daily life are not hydrating themselves is causing them to get ketoacidosis. It's low level of ketones that you make. That's how this drug works. Is actually cardioprotective. So sometimes it sounds paradoxical, but that's a very low level of ketogenesis that's helping as one of the mechanisms through which these drugs work.
We actually explain this, sir, using what we call the Robin Hood effect in India. So Robin Hood was a person who stole from the rich and gave to the poor. This is what SGLT2 inhibitors do. They steal from glucose-based metabolism and they give to ketone-based or free fatty acid-based metabolism. Now imagine our economy. We have a formal and an informal economy. We have white as well as black economy. Now, what will happen to the country if the entire white economy just vanishes? If all our money goes to Switzerland or perhaps to Harvard, the country will collapse, because where will we get money from? But at the same time, if the black economy collapses, this is what happened after demonetization, or the informal economy collapsed during the lockdown, then again we get into trouble. So if things are in balance, a little bit of ketosis, mostly glucose-based metabolism, then the myocardium runs fine. So Robin
Well
Hood
said.
also remained within limits. I mean, he fought in the forests of I think Sheffield. I'm not sure now.
Well
So
said.
yeah, but he didn't. It was Nottingham actually, not Sheffield. So he did fight in the forest, but he didn't try to take Nottingham city by force. So I think that is what SGLT2 inhibitors do. Sir, comments required on metformin in, you've spoken about pre-diabetes, but metformin in pregnancy, it is approved for use in India. But Dr.
Mhm.
Pushpam from Saharsa in Bihar says, sir, what is the drug of choice in gestational diabetes?
Insulin.
Clearly,
So
yes.
there's no doubt that insulin still has to be the primary drug. Under extenuating circumstances, yes, metformin can be used, definitely better than sulfonylureas. And I know even around the world, some people use sulfonylurea because they need to get the blood sugar down somehow. So I think the problem really occurs not so much in gestational diabetes, but in people with pre-existing diabetes who happen to get pregnant. That's an altogether different story. But with no doubt about it that metformin can be used, but it does cross the placenta. There are long-term studies still follow-up where these children who are getting to be at the age of, let's say, up to teenage are being followed. So more data to come, but metformin in glycemic control in pregnancy would be certainly the second drug.
From Baroda in Gujarat, Dr. Pradeep Seth has a query. Is this true, sir, that pioglitazone can cause macular edema? Or is it true that it is contraindicated in a person with pre-existing macular edema?
I think both are true. There have been reports of new macular edema, and I think it probably happens more so. I cannot quote you a paper, but let's say you had a patient on pioglitazone or rosiglitazone and insulin in combination, then the chance of macular edema will be higher. And that's one reason why we should remember that in patients on insulin, if you use these DZDs, the dose should be as low as possible. I know in India, people actually use pioglitazone as low as 7.5 milligram in the management. But of course, we find it very low dose in white population. So I think certainly no more than 30 milligram is the indication in combination with insulin. And I think it makes sense to avoid that higher dose in people on insulin.
In India, we usually use low dose, and 15 milligram is what is used most often in the country.
Right.
Many questions on diet. Let me take 3 or 4 of them together, sir. If you can just give your comments in a minute or so. And all these questions happen to come from Maharashtra, which happens to be our richest state and which happens to have some of the best cuisine in the country. So Dr. Meena, Dr. Pramod, Dr. Priyanka, all of them talk about intermittent fasting or a 2-meal diet pattern per day. We call it the Dikshit diet here. Does this make sense for a person with diabetes who is just on medical nutrition therapy? Does it make sense, a 2-meal pattern for somebody who is on oral drugs? And does it make make sense for someone who is on insulin? And maybe for a type 1 diabetic?
Yeah, definitely. I think that's a very practical and very important question. So I think there's intermittent fasting, which is very popular all over the world. Depends on how you define intermittent fasting, especially in people with insulin on board, particularly multiple insulin injection therapy, type 1 for sure, but in type 2 also, if somebody is on multiple insulin injection program, they clearly behave like people with type 1 diabetes. And that's not something that you will be advocating. It's like what we say to people during Ramadan period. And it comes down to more or less similar. So I think there's no doubt in people who are on no drugs, just on diet program, or on an oral agent, which can be used in smaller dose, particularly sulfonylureas. Intermittent fasting is okay, 2 meals a day, but I don't know whether skipping, if you skip the meal for the entire day, some people are doing alternate day intermittent fasting. In that case, certainly drugs like sulfonylurea cannot be used, but metformin could be used depending upon the blood sugar pattern. And I hear it occasionally from people who are on metformin. They get hypoglycemia on metformin. And maybe you can tell me your opinion, but we almost never see that. But apparently some people do complain of hypoglycemic type symptoms on metformin. So I think it's very individually based. And there are many types of intermittent fasting patterns. But I think be very careful in people who are on insulin, particularly multiple dose insulin program.
We do see hypoglycemia-like symptoms with metformin, and not infrequently, quite frequently.
That's very interesting.
The trick is to take a good history. You actually might have a normal capillary glucose. The glucometer says 90 or 100, 110. But when you take a history, the patient complains of neuroglycopenia. From a doctor's perspective, let me share some examples with you. You begin your OPD, you're in a smiling mood, in a happy mood, you're the best doctor in the entire Bihar or entire Maharashtra. By the time lunchtime comes, you begin to get irritated. You begin to get aggressive. The same patient, the same cantankerous lady who you would have handled very happily in the morning, she makes you lose your temper in the afternoon. It is not her fault. It is also not your fault. It is neuroglycopenia's fault. In fact, there was this study in Latin America, in Bolivia, where an American anthropologist, he propounded what he called the hypoglycemia aggression hypothesis. So he was studying various Indian tribes there, and he found that one particular Indian tribe was very aggressive, very hostile towards outsiders. All the others were very cool and welcoming. He went and checked glucose in everybody. At that time, it was called sugar, not glucose. And he actually found that their glucose levels were lower. Now, whether that study was conducted well or not, whether that Indian tribe had another reason for being hostile or aggressive towards the Americans, that is a separate matter. That is for the anthropologist to discuss. But in your OPD, in your practice, you will actually find that you become aggressive as and as you become neuroglycopenic. So ask your patients about this symptom. One Panditji whom I had, a religious leader, his complaint was, I begin my day happily. I sit down for puja, but he was speaking in Hindi, and he was a very literate, very erudite person from Yamuna in Haryana. This is published as a case report also. He said, the moment I begin to achieve anand or bliss while I'm meditating, something happens. Demons enter my head. And my meditation gets spoiled. I am not able to achieve God. I am not able to achieve bliss. What he was thinking is that he's being punished for some sins. So he kept on thinking that I must be doing something wrong in the other 22 hours of the day. That is why those 2 hours are going wrong. And when we took the history, it was not the demons who were troubling him. It was the glimepiride and metformin tablet that he was taking early morning without having breakfast, and then sitting down for puja, for meditation. We just changed the glimepiride to vildagliptin, and then all the demons ran away. Now, this is something that he would not have, reached out to any doctor just like that. That Pandit had to be very confident with me that I would not laugh at him. I would not sort of go to God and speak with the demons about him. So there's a lot of sensitivity involved.
Yeah. And so this is a perfect example of how you can be misguided by the fact that you are on one pill a day, which has metformin in it, forgetting the fact that the second pill could be playing the part on causing hypoglycemia. But I've heard this more so in Indian population. Whenever I come and visit, people talk to me about that. And I think it's not been published properly. Somebody should really put a nice account of this and publish. Because, for example, in the DPP trial, we had several thousand people, out of which more than 1,000 people were on metformin. And there was no, history of hypoglycemia that was documented. So this must be something to do. This comes back to, again, the genetic, personalized approach. There may be a gene that particularly interferes with the recovery from hypoglycemia, because that could be an effect of not starvation, but hypocaloric diet, let's say. And this particular case that you're describing, they could have had a small breakfast, and they have a gene that interferes with some other genes. And I think we may finally find that in certain populations, metformin can cause hypoglycemia. I have not heard that in many sources. Certainly it's not been documented. So I think it'll be good to document that. Maybe you can do a randomized study, even in like 100 people. It's not a very big study. Or a multi-center study with 500 people, then easy to find an answer, because you can do a CGM on these people, ideally, in this day and age.
Yes.
I think, just periodic blood sugar will not help. And I would love to see that kind of study where you do a CGM in a placebo-controlled manner in metformin versus non-metformin. Let's work on that.
So 2 clinical tips for everybody who is gathered with us. Number 1, if your patient has hypoglycemia, hyponatremia, or maybe hypoxia, all these can lead to a confusion, a state of mental distress. So be watchful for all these things in the OPD, especially during summer months, especially if your patient is on any kind of glucose lowering therapy. And diet, of course, is the pillar of management, but diet and medication should be concordant. You cannot say that I will follow a diet, any kind of an extreme diet, without talking to my doctor about what medicines are going on. And vice versa is also true. And do remember to focus on electrolyte, fluid, and glucose optimization. Another clinical tip would be that we must do glucose monitoring. But if any endocrinologist tells you that glucose monitoring can replace history taking, sir, your opinion about that, Dr. Om?
Yeah, no, I think glucose monitoring, again, based on individual circumstances. We were talking about metformin as an example, but people who are on a simple program of, let's say, metformin and DPP-4 combination, or metformin and TZD combination, or a triple therapy, which does not supposedly cause hypoglycemia, they don't have to monitor very often. A lot has been talked about this, but any hypoglycemic drug that one uses, and actually you'll be surprised how many people without diabetes who have just IGT or pre-diabetes can at times have a pattern which not necessarily hypoglycemia, but there's certainly times of the day when the glucose level drop. And the circadian rhythm has a certain role to play. People who travel a lot, and even sometimes something after travel, which should only take 3 or 4 days to dissipate, and some people may take much longer. So that's the shift workers. That's another example, who work, and then they change the shift periodically. So I think those are special situations where we are very fortunate to have CGM devices. And I believe some of these are widely available now in India, like Freestyle Libre, and certainly much easier to use than, say, Dexcom. So I think one has to really individualize the need. But I think many more people can use CGM than currently are practicing that. And I think this is really, they're not perfect. One still has to keep in mind, it's not a great device to detect hypoglycemia, but gives you a clue. Because anytime your blood sugar level drops to less than 80 or is much higher than 250, let's say, one must cross-check it with the finger stick, because none of these devices currently are that accurate in very low and very high range.
We must monitor glucose as per requirements, but we must supplement that with a history taking as well. And I would like to commend a questionnaire known as the Hypoglycemia Awareness Questionnaire, which has 12 symptoms. You can easily translate that into any Indian language and just use it. So make a habit of using this Hypoglycemia Awareness Questionnaire in every patient who is on insulin, every patient who is on sulfonylureas. So you've answered many questions for us. Dr. Khurshid Hassan had asked about high HbA1c. You've managed that. For prevention, of course, you have been highlighting the need for diet and exercise, lifestyle modification. Dr. Anil Masne had asked that question. Dr. Suresh Pawar from Thane thanks you for a very informative talk. Dr. Vishnu Mulchandani, again from Maharashtra, says, at what age do you start screening for diabetes in USA? And what would you recommend for us in India?
So this is another important question, a practical question. So I think even though people thought way back that there's no need to screen people for diabetes below the age of 40, see how far we have come. If you have a strong family history of diabetes, which I think is the most important thing to keep in mind, and if you are gaining weight with a strong family history of diabetes, and if you have high triglycerides, something that is really very, favorite topic of mine. High triglycerides are really an indirect reflection of insulin resistance. So, of course, in women, history of large babies or history of small babies, both are pre-diabetes indicators. And again, you can add other things to it. History of depression, which is not often quoted as a risk factor. So I think all of these, the more risk factors you have, the earlier you should be screening. I would say if type 2 diabetes is the concern in a family history being very positive, then with weight gain, I would start screening at age 30, although many of the guidelines say age 40. But now you see, you look at all around the world, we have type 2 diabetes occurring in younger and younger people, especially overweight people, and even adolescents and children. In Japan, where type 2 diabetes, where type 1 diabetes is still uncommon, like in India, type 2 diabetes in children is more common than type 1 diabetes. Okay, and the same may be happening in India as well. So I think the index of suspicion really should go up. There is an online risk calculator on the ADA website, which is helpful. But again, main emphasis in that is you get more points if you have strong family history of diabetes, by which we mean first-degree relatives, your parents or your siblings.
Let us look at what Sir has said from an Indian clinical perspective, an Indian OPD perspective. We give risk factors and we give scoring for chronic complications or for metabolic diseases, obesity, hypertension, family history. But in India, more often than not, you will have to screen for diabetes in an acute setting. So any infection, especially tuberculosis, hepatitis, sexually transmitted disease, genital tract infection, HIV/AIDS, and these days dengue and COVID, you have to screen. If you're treating malaria, screen for hypoglycemia because the drugs can cause hypoglycemia. So do remember that as an Indian clinician, you have to wear two turbans at the same time, that of a chronic care provider and that of an acute care provider. And you will actually find a lot of uptake or a lot of positives when you screen these people for dysglycemia. They might have stress hyperglycemia, they might have diabetes, but that is then the second step for you to figure out. But don't forget to screen all patients with refractory, resistant, or recurrent infection for diabetes. Please don't forget that. Sir, you've answered Dr. Priyanka's question about metformin being safe. I think our discussion has revolved around metformin today. And you also answered Dr. Aditya Mahajan's question. He's from Gondia in Maharashtra, where he spoke about lean patient, when you spoke about the phenotype, insulin resistance versus insulin deficiency. And if there is insulin deficiency, then it has to be insulin, Aditya. If they don't agree, do not write a tablet, please. If you know you've diagnosed type 1 or pancreatic diabetes, be polite with the patient. Tell the patient, I cannot do you harm. This is what is required. In my OPD, many times I say, allow me to switch to Hindi. ये हमारे कर्म है, मेरा इस पे कंट्रोल है कि मैं क्या कर रहा हूँ. My work is to give you the right medication, to counsel you correctly. I am willing to do that. Spend as much time as you want with us, solving your queries. But if you're going to expect me to write the wrong medication, that is not possible. Now, this was my responsibility. It was your right to ask questions. But you also have responsibilities, and your responsibility is to take care of your body. That is up to you. If you do not accept the medication that we are offering, you have a right to leave. So whenever you, don't be rude with the patient, but say whenever you are ready, whenever you're in the right frame of mind, do come back. If your patient happens to be in a life-threatening, limb-threatening, or organ-threatening situation at that time, then you have to be more firm. But again, if the patient doesn't agree, it would be much safer to refer to a tertiary hospital and ask them to go there because they're in a life-threatening state like TKA, or maybe a limb-threatening state like diabetic foot, and you're worried about an amputation. We continue to have questions, sir, but it's already 100 minutes. Allow me to take two more questions which are not related to glycemic control, just brief questions, sir. One question is diabetes remission, diabetes reversal. How frequently do you see it in your clinic? What are the words that we should use when we counsel our patient?
Yeah, so I think this has become a buzzword these days, actually, in the last couple of years, since a couple of studies have come out that have said that if you have a certain amount of weight loss, you can have diabetes remission, which is true. It has always been true. There's nothing new about it. We have now 1-year data from a large study and a 2-year data from another study. So there's no question that type 2 diabetes, I wouldn't call it is reversible. I would still call it a remission and under good control. Just like we see in type 1 diabetes, you can have a short-lasting so-called honeymoon period or remission, but unfortunately that's really short-lasting. In type 2 diabetes, it all depends upon the nutritional management and the weight loss and maintenance of weight loss and all of those factors that we talked about in reducing the burden of glycemia, because hyperglycemia begets hyperglycemia, and the reverse is also true. So I think, yes, one can achieve diabetes 2 remission, one can say, but one should never think that they cured their diabetes, because all it takes is several weeks of wrong eating or a lot of stress or whatever, that you can have high blood sugar levels again. So yes, it's achievable, and now more so, because in addition to nutritional counseling and lifestyle changes, we now have agents like GLP-1 receptor agonists that we talked about, and that we are going to be seeing more people achieve diabetes remission. We know from bariatric surgery, for example, there's a fairly good number of people who go off of the diabetes medication even before they lose any weight. So that's a different story we can talk about some other time. But there are some gut hormone changes that is taking place, and we didn't talk about that in today's limited time. But microbiome is extremely important in manipulating your metabolism. And I think if you change your diet, let alone lose weight, you can still try to change your microbiome, particularly if you achieve significant weight reduction. So these are all very important topics we can discuss some other time.
The gut microbiome is known as the second endocrine system of the body.
Right.
It is also known as the second brain, because few of us would know that 90% of the serotonin in the body comes from the gut. It doesn't come from the brain. But a question from Dr. Meena from Thane. What is the role of prebiotics and probiotics in prevention and management of diabetes? What probiotic, prebiotic would you recommend for us in our daily diet?
Yeah, I think again, it comes back to the microbiome question, that we really are able to change some of the microbiome with the prebiotics and probiotics, but it's the long-term effect that we're looking for, and how long the person can sustain a given diet plan. So I think in any diet plan, prebiotics, probiotics can assist with the goals that you're trying to achieve. But ultimately, I think one still, especially in people with diabetes, glycemic control and weight management will cause long-term cardiovascular benefits. And this has now been very clear from some of the animal data. You can take the microbiome from an obese rat, for example, and put it in a control animal, and you make that control animal obese. And the reverse is also true. A lot is being talked about. Something again we didn't talk about is the effect of paternal genes. Again, this is digressing from this question, but these epigenetic changes that occur. And we talk about, how to prevent the diabetes progression or diabetes onset in people, in younger people. So we used to think only of maternal nutrition during pregnancy. Now we're talking about paternal nutrition as well, before the formation of the zygote. So I think these are very fascinating questions that, of course, will require a lot of time to discuss, but we certainly can have this discussion some other time.
Discussion on it. But Dr. Meenal, your question was prebiotics and probiotics in our diet. I think 250 grams of curd or yogurt a day would be a very pragmatic way of counseling your patients.
Right. And it's very common in India. A lot of people use yogurt as part of their diet.
Haryana, sir, is the state of दूध दही का. So Haryana हमारा state है जिस दूध दही का खाना होता है. So we don't say butter, we don't say ghee for our state. We say milk and curd, milk and yogurt. That is how we speak about our state here.
Mm-hmm.
Sir, two out of the box and out of syllabus questions. Dr. Anupam Agarwal says, if I'm pre-diabetic, hypertensive under control, normal lipid and glucose parameters, but he hasn't specified his LDL, can I take a Torvastatin every second day?
This is, again, something that, well, there are issues about that. If the blood pressure is normal, the lipids are normal, and the person does not have diabetes, there is no real scientific reason for that person to be on a statin. Keep in mind that there's a small incidence of developing diabetes on statin. Okay, we didn't talk about that, but that's a huge topic by itself. So there have been studies now and meta-analysis, and I was asked to actually comment on that by the press the other day, because one study that just came out from VA population, very large number of men that were studied, and they showed worsening of glycemic control with statins. So it's not just simply converting pre-diabetes to diabetes on statin, but even slight change in the blood glucose control. Having said that, when you need statin, if you're high risk, don't be confused by that finding, where sometimes the news media inflate it. The incidence of worsening diabetes control is still relatively small. The A1C rise occurred in like 0.2% in that big study that they presented. More importantly, who are the people who get diabetes while they are on statin? First of all, if they need statin, they should be on it. But secondly, all of these people, virtually all of them, have pre-diabetes to begin with, which may not have been diagnosed. And final answer to that question also has to be that when you put somebody on statin and they think that now their cholesterol is going to get much better, maybe they start eating a little bit better, whatever better is. So you know what I mean by that. So that also plays a role in inducing diabetes in people on statin. So in this particular case that this physician is asking about, I would say you can calculate the 10-year risk of cardiovascular disease by the PRC calculator that's widely available. I carry it in my cell phone all the time. But in addition, keep that in mind, it's age-related as well. So if you're above the age of 60 or 65, you will certainly have high enough risk because cardiovascular disease is so common. But again, depends on the level of LDL cholesterol, level of blood pressure control, and your family history, which by the way is not included in any of the calculators, which is certainly a big limitation of these calculators.
I hope, Dr. Anupam, that answers your question. And then the last outer syllabus question is, this is from Dr. Gangadhar Rath. What is the role of hexokinase in diabetes management?
I'm not familiar with that. Hexokinase is a key enzyme that is required for the phosphorylation of glucose, but I'm not sure exactly what they mean, something like that.
Maybe, Dr. Gangadhar, what you mean is the glucokinase activators, and they are under trials still. So they have not reached the market.
There are many new drugs that are currently under clinical trials. Imiglamin is another one that we didn't talk about. Yes. Imiglamin is actually going through clinical trials, and there are literally dozens of new drugs that are undergoing clinical trials.
Sir, it's been nearly 2 hours now, and I'd like to acknowledge and appreciate your time. Our theme for today's World Day was access to diabetes care. And on behalf of everybody who has logged in, everybody who has asked the questions, it's very rare to have such an interactive discussion. And it's extremely rare to have it at 11 p.m. at night on a Sunday. But
I really enjoyed this, and thank you for moderating the session and bringing up some of the important points from the Indian perspective.
This is what access to diabetes care means. It means access to diabetes expertise as well. Like always, we have a quiz for you. This week's quiz is something special. What is the sodium to potassium ratio of NRSL 0? Why don't you write it down in the chat box? And a special goodie box from Dr. Om Ganda will reach you. What is the sodium to potassium ratio of NRSL 0? That is the first question. And the second question is, how much carbon dioxide is there in 400 ml of NRSL 0? First question, what is the sodium to potassium ratio? And the second question is, how much carbon dioxide is there in 400 ml of NRSL 0? Please put in your answers, and we look forward to meeting you again next week. I'd like to hand the floor back to Rahul Desai before we conclude. And Dr. Om, a personal thanks for us as well. It's been great learning from you, sir.
Thank you. Thank you for moderating.
Thank you, Dr. Om, sir, for sharing your views on today's topic of pragmatic approach to choice of glucose-lowering therapy. I wish we would have more time, but it was great listening to you on your views and your guidance and your opinions to help our physicians take more approach towards provide access to diabetes care. Thank you, Dr. Kalra, sir, for moderating the session and sharing the actual views of the Indian doctors who face in their daily OPD. I thank all the viewers for taking out time on this Sunday evening and attending this session. For all those viewers, every Sunday we are conducting daily one module live with Dr. Sanjay Kalra, sir, where he takes one topic pertaining to diabetes essentials. If you have not attended this session or missed any session, soon you will be getting a link where you can attend the session and get more hands-on approach. Thank you so much. Good night.
Thank you.
All the best. Good night.